Acute pyelonephritis in adults. So the clinical features of acute pyelonephritis are the patient complains of flank pain, nausea, vomiting, fever, costovertebral angle tenderness. And it may present with or without the symptoms of cystitis. So the patient can have cystitis and acute pyelonephritis both, and he can have the symptoms for both or not. Then we have the investigations. If you are suspecting the patient to be having acute pyelonephritis, we are going to investigate it with the midstream urine microscopy and culture. And when that was the patient of acute cystitis, we were not going to investigate him if he is a non-risk patient and he is having the first or second episodes of UTI. But if the patient has acute pyelonephritis, we have to investigate the patient, and it is usually unlikely if the pyuria is absent on urinalysis. And patients who require IV therapy and hospitalization, we have to obtain the blood culture before antibiotic therapy is given. Imaging is also done when we are suspicious of kidney stone or ureteric stone or renal abscess, especially if the patient remains febrile after 72 hours of antibiotic. We are going to suspect renal abscess and we are going to do the imaging for that. And if the patient is male, we are going to do the urological evaluation. Now, the management and the patient in the non-pregnant adult males, in the non-pregnant adults, we are going to give the higher dosages of beta-lactam, and the higher dosages of beta-lactam should be used to ensure the adequate antimicrobial exposure. And oral therapy is given, and it can be amoxicillin plus clavulanate. And if the patient has hypersensitivity to penicillin, ciprofloxacin can be given in place of amoxicillin. And if the pathogen is susceptible to any of the therapy, to other therapy drugs, so we are going to stop the amoxiclavulanic or ciprofloxacin, and we are going to use the narrowest spectrum. For example, we are going to use the amoxicillin alone if the patient is susceptible to amoxicillin or trimethoprim or sulfamethoxyl or cephalexin. If the patient is susceptible to these drugs, we are going to start the therapy with the narrowest spectral drug after the culture reports. But before the culture, we are going to start the patient with amoxicillin or clavulanate, and if the patient is hypersensitive to penicillin, we are going to administer the ciprofloxacin. Fever may take up to 48 to 72 hours to resolve, but patients start to report of feeling better. So by this, we can say that the antibiotics are responding. The patient is responding on the antibiotics. Then we have, if the patient has ongoing symptoms despite the antibiotic therapy, we are going to get the expert urological advice. Now, if the patient has severe symptoms and he cannot tolerate orals, then we are going to administer the IV therapy, because most of the times acute pyelonephritis patients have nausea and vomiting and they are not tolerating the oral drugs. So we have to give the IV therapy. And in IV therapy, we can give the gentamicin or tobramycin IV. And in patients whom IV therapy is to be continued for more than 72 hours, for example, if the patient has severe symptoms or if the patient is high-risk patient, and he has just some risk factors for severe disease, so we are going to give the ceftriaxone in the first place instead of the gentamicin or tobramycin. And if the patient has severe hypersensitivity reaction to penicillin, so ceftriaxone would be contraindicated, and then Genta or Tobra would be the drugs that would be given. In the ER setting, single IV dose can also be given, and we can then discharge the patient on oral, and it can be done once clinically improves. So in the ER setting, the patient comes to you with the acute symptoms of pyelonephritis, and if you give the single dose of IV antibiotic and he gets clinically improved, he start to clinically improve, then we can discharge him on single IV dose, and we can discharge him with oral antibiotic. If the culture result is susceptible to amoxicillin or then we can also give the amoxicillin or ampicillin to the patient for oral. So the total duration for the acute pyelonephritis treatment is IV plus oral is actually 7 to 10 days. And if the patient had the antibiotic course with ceftriaxone, so 7 days would be enough. Now, if the patient has sepsis and septic shock, and you are suspecting that the source is from the urinary tract, and the patient has urinary tract infection that led to sepsis and septic shock, what would be the management? So we are going to start the antibiotic within an hour of presentation of sepsis or septic shock. And empirical therapy for sepsis from urinary tract in non-pregnant adults would be gentamicin or tobramycin or IV ceftriaxone. And if the patient is at risk of multi-drug resistant, we are going to give the meropenem IV. And if the patient is pregnant, we are going to give the gentamicin or tobramycin IV plus amoxicillin or ampicillin or single drug ceftriaxone. So in pregnant patients, these two drugs should be given, genta or tobra plus amoxi or ampicillin. So if the ceftriaxone is used, so single drug ceftriaxone is used. And if there is a risk of multi-drug resistant gram-negative bacteria, meropenem is to be used. And if the patient is with septic shock, so we are going to be using the ceftriaxone plus gentamicin or tobramycin. And if ESBL bacteria, example E. coli, is suspected, amikacin may be preferred.